So we are live now, guys. I'll go ahead and start. I'm so sorry for the delay. We Americans are not really very savvy with the computers, so we needed help from Pakistan and Middle East, I guess. But we know that Rob Haas is here to present, and there's nobody in the world who does ERCP and doesn't know Rob Haas. So he really does not need any introduction, and same goes for any type of complex endoscopy. And I'm really fortunate enough to have him as my teacher, and pretty much all I know in the field of endoscopy, and it's really because of him, and he have taught almost half of the world. He's not really just a good endoscopist, he's really a compassionate endoscopist and takes care of his patients like they are his own family, and I really, really admire him. I have been very lucky to have him right beside me every day, and can see him every day, seek advice, whatever I need. And whenever I'm stuck, I'm like, where is Rob? Call him. And even if he's in Charleston, we call him and find out he may be in Japan, he answers his phone. So really, I can go on and on and on for all day, and still that would not be enough to introduce him. So Rob, I think we should go ahead and start the presentation. We're kind of running late, but it's really an honor and privilege to have you and to introduce you on this forum, and stage is yours now.
Well, thank you so much, Mohammed. The feeling is mutual between you and I, and it's been a great privilege to be with you over this last sort of 9 years and so forth, and also as a trainee. And I really want to thank Gias and Saad for putting this together. And I'm really very, very pleased to be with you. So I've been asked to talk about, if you go to the prior slide, Mohammed, so I've been asked to talk about the assessment and management of biliary strictures. So I will do my best to do that. Next slide is my disclosures. I'm a consultant with Olympus, but this really does not affect my my presentation. So if you look at biliary strictures, I divide them into benign, malignant, and then indeterminate. And I think that the benign ones basically boil down to chronic pancreatitis, post liver transplant and post-operative. There are others, but those are the main ones. I do not have time really to talk about PSC. I think that PSC is a talk in and of itself, so I will not touch on PSC. If you look at malignant, I divide them into proximal or distal, so the location of the stricture I think is most important. And then there is the indeterminate stricture, and those are the ones that are really quite difficult for us to manage. Next slide, please. So when you're establishing a diagnosis of indeterminate biliary strictures, there's a number of tools that you have to make that diagnosis. History is critical, I think, in this day and age of scanning and tests and so forth. I think we lose the power of history, but really understanding the history of the patient can go a long way to understanding the nature of a biliary stricture. Of course, the revolutionary change for us has been in MRI with Mrcp. That's been an unbelievably powerful, non-invasive way to evaluate the biliary strictures. We have EUS with or without FNA. And I put just a little bit of a caveat, at least for Western populations. If you have a patient with cholangiocarcinoma, if that patient has any possibility of being a transplant candidate, and we are transplanting some patients for cholangiocarcinoma, at least here in the United States, you need to avoid EUS-guided tissue acquisition. It will cause recurrence in the transplanted liver. And then we have ERCP, obviously, and as part of ERCP, we have an old modality that isn't used very much, intraductal ultrasound, but we have tissue acquisition and bile cytology. Fluoro-guided biopsies are all possible with EUS. And then I've put into a separate category single operator cholangioscopy with biopsy, because this, I think, has really revolutionized the diagnosis of indeterminate biliary strictures, and really tissue is the issue in indeterminate biliary strictures. Next slide, Mohammed. So this is an old slide. The Koreans have really taught us this. We don't use it very much. We do have a mini probe that goes over a guide wire in our unit, but I must admit we don't use it very much. But the Koreans in particular have categorized different patterns of benign and malignant strictures using intraductal ultrasound. So if you have it available, then you should use it, I think. Next slide. You have to double click on this one. Thank you. So for methods of sampling with ERCP, we have brush cytology and then fluoroscopic guided biopsies. And this has been a problem for a long time. Brush cytology is not very sensitive. I think a lot of that is because many pancreatic cancers, the cancer is not invaded sufficiently into the lumen of the bile duct for the brush cytology to pick it up. Obviously, cholangiocarcinoma, distal cholangiocarcinoma will be picked up by brush cytology, I think, more often. But overall, the sensitivity is really, and accuracy is quite low. Fluoroscopically guided biopsies, again, the overall cancer detection rate is relatively low, and this is bothersome. So the next slide, it shows the single operator cholangioscope, the so-called Spyglass DS from Boston Scientific. I realize that this is it's a major expense issue, and around the world, this is really a critical issue, and it's a little bit sad because this is really a remarkable piece of technology. As you can see on this slide, it's a single operator system. There is a channel for suction and for biopsy forceps. There's a separate channel for water infusion. It has a consistent four-way tip deflection. It's plug and play, so you just plug it in, hook up the water infusion and the suction, and you're ready to go. I think it's really a remarkable a piece of technology. It's just that it's expensive. And Boston Scientific has improved the biopsy forceps, so tissue acquisition is better with this, and this is really a backbone technology, at least for us, in evaluating indeterminate biliary strictures. So the next slide, Mohammed, it should be a video, and you'll have to click on that. Thank you. So this is a video of a cholangiocarcinoma that I took in CIE. You can see here just visually these very dominant, dilated, kinky, so-called tumor vessels. And I think that as we observe this, you can see that how blind biopsies could miss this. This is a focal lesion. If you happen to hit distal to it or maybe proximal to it, or on the opposite wall, you can't see this under fluoroscopy. And so here we've introduced the mini biopsy forceps. We're fortunate in this case to get nice and perpendicular to the lesion. Close the biopsy forceps slowly so it can grab the tissue and then withdraw. With this new Spyglass system, the biopsy forceps come out at the 6 o'clock position always, and this is also very, very good for getting tissue and for orienting the biopsy forceps. So you can go on to the next slide now, Mohammed. So this is a study done in CIE looking at tissue acquisition and indeterminate biliary strictures. On the left-hand slide is brush cytology plus blind biopsies without an immediate read. So in this study, rose tick is essentially a technique in which the biopsy is taken. It's then gently rubbed onto a slide, and then that slide is prepped in the same manner as we would with an EUS FNA. So it's smeared and stained and then looked at immediately in the room. So on the left-hand side, we have brush cytology plus blind biopsy without rows. Next, we have directed biopsies with the SPY scope, but without rows. And then on the far right-hand side, we have directed biopsies with cholangioscopy, plus the immediate looking at the slides in the room. And you can see that obviously on the right is really very, very impressive results with a sensitivity of 100% and a specificity of 89%. So we think, at least in our unit, that directed biopsies with in-room preparation by rows offers the best way to diagnose indeterminate biliary strictures. Next slide. So when you're establishing a diagnosis in benign biliary strictures or suspected benign biliary strictures, again, the history is critically important. Do they have a cholecystectomy recently? Do they have any evidence of chronic pancreatitis? Obviously, have they had a liver transplant? Many of the benign biliary strictures can be at least highly suspected of the etiology based on history alone. And then we have great cross-sectional imaging with multi-detector CT and MRI. And then, of course, we have EUS plus or minus FNA. So I think the diagnosis of benign biliary strictures with the modalities mentioned on this slide is really pretty accurate. Next slide. And then for establishing a diagnosis in suspected malignant biliary strictures, if it's a distal stricture, then we're advocates of EUS FNB. You notice that I put FNB here as we have gone almost exclusively now to the new design bevels on the EUS FNA needles. If it's a proximal biliary stricture, Hiler or above, then we advocate cholangioscopy with directed biopsies, and as mentioned in a prior slide, rows as well. Next slide, Mohammed. So now we move to management of biliary strictures, and I divide these into benign, malignant, and then indeterminate. And I'll put in a plug here. Mohammed will be extra sensitive to this because he's deals with a number of these patients. I think all of us in our unit, we maybe get 4 to 6 of these patients a year. But if you have an indeterminate biliary stricture, if you do not have a confirmed diagnosis of cancer, please put in a plastic stent or a fully covered stent. Never, ever, ever, ever put in an uncovered metal stent unless you have a definite diagnosis of malignancy. So not suspicious, not highly suspicious. It needs to be a definitive diagnosis of cancer before you put in an uncovered metal stent. Next slide. So the general approach to endoscopic treatment of benign strictures, number one, get a complete cholangiogram. Sometimes you should compare this to an MRI. If you have a duct injury and you have an excluded portion of the biliary tree, you may not ever get a complete cholangiogram. And so it's important sometimes to compare that to the Mrcp. Once you identify the stricture, cross it with a guide wire. And then I think most of us will do a balloon dilation. And again, just a reminder that you can dilate that stricture up to the diameter of the bile duct distal to the stricture. So frequently it's the bile duct is dilated upstream of the stricture, but the balloon that you select should be the maximum size of the stricture of the bile duct distal to the stricture. You can then use plastic stents, and if you do that, you need to repeat the ERCP every 3 to 4 months with upsizing, and you should probably do that for 12 months, up to 12 months. Or you can use a fully covered metal stent if you can stay far enough away from the bifurcation. And in that case, you should reevaluate somewhere between 6 and 9 months. Next slide. So this is a definitive study. Greg Cote published this in JAMA. It's a randomized trial of metal versus plastic stents for the management of benign biliary strictures. It was a dominant number of liver transplants in this study, and then 35 chronic pancreatitis, only 4 post-operative patients. So that's a less represented group of people. And they were randomized to either metal or plastic stents. The sample size was calculated for non-inferiority of the metal to the plastic stent. And if you got randomized to a plastic stent, you got an ERCP every 3 months with upsizing. If you got a metal stent, then you were reevaluated at 6 months. The primary outcome was stricture resolution after no more than 12 months of therapy. 55 patients in plastic and 57 in the metal. And the bottom line is that the overall success for plastic was 85%, for metal was 93%, and that was statistically significant. That's statistically significant, meaning that there is no inferiority for the metal stent. So this just proved that the two are essentially equivalent. But the finding in this study, as with other studies that have randomized patients, is that you can successfully treat the patient with fewer ERCPs if you're able to use a metal stent rather than plastic. Next slide, please. Just a sobering study. That's a very old study from Jacques Bergman from Amsterdam in 2001. But I just put this up here because we get very enthusiastic about treating benign biliary strictures. We poo-poo the surgeons and we tell them that we can treat most of these patients really, really effectively. But this is a study that I think takes away some of the veneer from the endoscopist and looks critically at the whole group of patients with an intention to treat. So this was a long-term follow-up after endoscopic treatment of postoperative biliary strictures with plastic stents. They started out with 74 patients, and the treatment was dilation and 2 10-French stents for 12 months. And then, as you can see, click the button, Mohammed. As you can see here, that 15 patients failed, and there were 2 deaths in the follow-up. So that takes us now down to 57 patients. Of those 57, actually 10 failed the protocol. So they didn't show up, they were lost to follow-up for whatever reason they failed the protocol. So that gets us now down to 47 patients. And then click on the slide again, and out of those 47 patients, 38 had stricture resolution with a mean follow-up of 9 years. Now click again, Mohammed. During the course of this treatment, 40%, there were 40% complications during the stenting, so cholangitis, jaundice or whatever, and then 34% had late complications, primarily restenosis. So click again, Mohammed. So in the end, if you look at the successful outcome, do you measure it on an intention to treat, which gives you 51% success rate, and for that 51% success rate, 40% have complications and 34% obviously failed? Or do you relate it, go back, Mohammed, or do you relate it to 81% success rate of 38 out of 47? So I just, I put that up there to just, for those endoscopists, me included, who think that endoscopy cures everything and it's simple and non-invasive. This is just a little bit of a sobering study to put us back in line. Next slide. And sort of apropos to that, we should never forget our surgical colleagues. They are our savior in many circumstances. They do excellent work, and certainly they do play a role in the management of benign biliary strictures. The only caveats I say is, number one, get a very experienced surgeon. A general surgeon may be very experienced in lots of things, but they may not be experienced in working with the biliary tree. Endoscopic treatment failure does not adversely affect surgery, so most of us will embark on endoscopic therapy first. Hiler strictures are difficult for both of us, but particularly for surgeons. There's really no fantastic, good randomized trial to help us make these decisions. And then what has evolved over time is that choledochojejunostomy is now favored over choledochoduodenostomy for chronic pancreatitis patients. Next slide, Mohammed. So now we go to malignant strictures. Next slide. And these I've divided into distal and proximal. Next slide. The distal ones I think are pretty straightforward. Next slide, Mohammed. I think it basically is now metal stents for most of us in almost all circumstances. And the reasons for that is that multiple randomized trials and multiple systematic reviews and meta-analysis have favored metal stents. There's an increased application of neoadjuvant treatment in pancreatic cancer. And so this has affected us, meaning that patients need much longer duration of stenting to undergo the neoadjuvant therapy. If you position a metal stent properly, it does not prevent a subsequent Whipple resection. And really, we have no accurate method to predict survival when patients first present. So when they present with jaundice, the old axiom was that if they're going to survive less than 3 months, you put in a plastic stent. If they survive more than 3 months, put in a metal stent. But the fact of the matter is that they can look very, very wobbly when they first present, but they're stented, their jaundice goes away, and they perk up, and they live a lot longer than we initially anticipated. So I think that metal stents now are the way of choice. So that leaves us now with proximal biliary strictures, and Mohammed knows that these I find very, very, very difficult. I find proximal malignant strictures difficult. Next slide. So I want to basically give a bunch of sort of requirements, thoughts, axioms, and so forth when you're facing patients with proximal biliary strictures. First of all, if you want to deal with these patients, you really have to have a knowledge of the liver lobes. That's, I think, a critical thing to do. Number two, I believe that a baseline Mrcp is critical before you embark on Ercp. So get a baseline Mrcp, look at the cholangiogram carefully with Mrcp. Understand and know the bismuth classification that has an effect on your management. You need to use an X-ray machine that can provide you optimal projections of the bile duct. A single projection is generally not adequate when you're doing complex drainage of proximal biliary strictures. Know what and how much of the biliary tree to drain, and then don't be a hero. There are circumstances in which we do harm to these patients. So we think that we can drain them. We embark on a drainage procedure. It was doomed to failure. And then we've converted a patient who had painless obstructive jaundice to one with cholangitis, infection, pain, and they have a miserable quality of life for the time that they have left. So here is the liver lobes. On the left is just a netter kind of a thing, and then on the right is an Mrcp. Again, you need to know the liver lobes. The right lobe is about 60% of the parenchyma, and the left lobe is about 40%. And you also need to understand from cross-sectional imaging whether there is atrophy of the lobe. So there is no point in stenting a part of the liver that's severely atrophied. You get no functional benefit out of stenting that area. Next slide. So the bismuth classification, click again, Mohammed. So bismuth 1 is basically the common hepatic duct is involved. Bismuth 2 involves the right and left main duct. Bismuth 3, A and B, affects either the secondary branches of the right or the left. And then a bismuth 4 affects secondary branches for both the right and left. So beware of the bismuth 4. They are very, very, very difficult to successfully drain. Next slide, Mohammed. So the two components of stenting Hiler strictures, one is access and one is stenting. Next slide. In terms of access, that's the first critical step. Study the MRCP and have a game plan. So maybe your game plan is that you can successfully drain the entire right lobe of the liver and that is what your goal is. Then stick to that. And if the wire goes into the left lobe, then withdraw it and redirect it. So have a study plan or have a plan based on the MRCP. Probe with a guide wire alone and avoid an occlusion cholangiogram. An occlusion cholangiogram likely will put contrast in ducts that you cannot drain or are unable to drain. So probe with a guide wire alone, and you can tell if the guide wire is in a significant branch, it will go easily and it will go way to the periphery of the liver. And if that's the case, then you may want to go ahead and opacify that segment. You can use a balloon and inflate the balloon or deflate the balloon to get different angles with the wire. You can use a torqueable curved guide wire. You can use a papillotome. Some papillotomes can be rotated. You can use the so-called swing tip catheter made by Olympus. All of these devices will give you various angles that you need to get the guide wire into specific segments. Opacify after the guide wire is in a good position by fluoro, and then balloon dilate all accessible areas. Next slide. In terms of stenting, if you're in doubt, please put plastic. Don't put an uncovered metal stent in an area that you don't know will effectively drain the patient because it's there permanently and will affect other access. 7 French is perfectly acceptable if the distal bile duct is small or you're unable to dilate the strictures effectively. You can come back after a 7 French has been put in, and then you can upsize it usually. Uncovered only, never ever put in covered stents in the hilum. Metal stents only if you're sure of your drainage. So if you put in plastic stents, the bilirubin normalizes, then you can come back at the first exchange and put metal stents in the same place you put the plastic stents, and you can get good drainage. Try to do side by side with the distal end and the duodenum because that's easiest to intubate. And then match the metal stent diameter to the bile duct. So avoid putting a 10 millimeter wide metal stent in a 4 millimeter or 6 millimeter peripheral bile duct. Next slide. The importance of liver volume has been now documented very well. This is a retrospective study of 107 patients. They were mixed bismuth 2, 3s, and 4s. And they did volumetry of the 3 main sectors, which is left lobe, right anterior, and right posterior. And then estimates were made of the percentage of liver that was drained during the stenting. And it was categorized into less than 30%, 30 to 50, and greater than 50%. And basically the primary factor associated with effective drainage was greater than 50% of the liver was drained. And draining greater than 50% was especially important in bismuth 3s. So in bismuth 3, you've got to get into one lobe, and then you've got to get a second stent into another major branch on the other side. Drainage of atrophic sector, which I mentioned earlier, was useless and associated with increased cholangitis. And then drainage of greater than 50% of the liver was associated with longer survival. Next slide. Drain what you opacify. I'm not going to go over this slide in great detail, but the bottom line is you should only drain what you opacify. And if you opacify everything and then only drain part of it, you will get cholangitis, and that will not be good for the patient. And this is a sort of an okay setup. You can see here that both stents are actually up the bile duct, but here we have left and right uncovered stents, and this will supply good drainage, and this patient will do well. And I think my final slide is this one, just highlighting the principle that I said earlier with Hiler strictures. Use MRCP and metal stents once you have identified effective drainage of the liver. And the last 3 studies in this show that if you use MRCP and you use metal stents, that really the cholangitis and incomplete drainage is very, very, very low. So it's a much more effective way to drain these. And the final slide, so use MRCP to drain, and SEMs are superior to plastic stents. But again, use plastic stents early on, at least initially. And finally, just the last slide there, I always want to express my thanks to my partners. Really, none of us could do our work without the collaboration that we have, and none of us could travel when travel was appropriate without the help of our colleagues. So with that, I'll close. Mohammed and Gias and Saad, and I'm sorry for the delay in the presentation. Certainly happy to take questions if we have any.
Rob, thank you so much. I think there was some technical issues maybe on our part. We apologize for that, and but it was an excellent presentation as usual. And I'll open it to Dr. Saad and Dr. Gias to take if there are any questions.
Thank you, Rob. It was an excellent presentation. There are lots and lots of questions for you. And the people have been very thankful to you, first of all, for giving such a wonderful talk. First question has been posted is, fine needle biopsy of distal CBD strictures quite challenging with unpredictable yield. What is your take on that? Which needle do you use for sampling these, and do you sample them or not?
So yeah, a distal bile duct stricture?
Yeah, distal bile duct strictures.
Yeah. So yes, I definitely sample those. And I use EUS guided sampling for any distal bile duct stricture, whether the origin of the tumor is in the pancreas or the origin seems to be in the bile duct, either way. And as I mentioned earlier, at least in our unit, based upon the studies that we've done, and based upon this very, very strong trend to molecular profiling more and more pancreatic biliary tumors, we've gone to the new generation of bevel needles, the so-called FNB needles for tissue acquisition in that circumstance.
One of the questions has been posted by Dr. Naqvi. You mentioned about dilatation of the stricture up to the diameter of the bile duct below the stricture. How would you judge that in the case of a lower CVD stricture, that is chronic pancreatitis?
Yeah, so that's a good point. I mentioned dilation only in proximal biliary strictures. I don't know what Saad and Mohammed's experience is, but I almost never ever have to dilate a distal bile duct stricture. The forces are with us with Ercp when it's a distal bile duct stricture, whether it's pancreatic or a bile duct stricture. I very, very seldom have to dilate that. If you really can't get in, then I would dilate, enough to get just a stent in. So a 4 millimeter dilation would be fine. But again, for me at least, distal bile duct strictures, I don't have to dilate.
I totally agree with you, but if I can just say that what my understanding is that I thought that you meant when you're dilating the proximal strictures, you do not want to dilate beyond the diameter of the proximal duct.
No, the distal.
So when
let's say you have a common hepatic duct stricture.
I mean, I'm sorry. I mean distal and yeah. Sorry, I mean the distal duct.
So
with the intrahepatic ducts, you really have to be very careful when it comes to dilatation for placing a stent. That's what I meant.
Yeah. So if you've got a 3 millimeter common bile duct, you then encounter a Hiler tumor, and then the right and left intrahepatic ducts are 10 millimeters in diameter. You can only dilate maybe 3 or 4 millimeters. Because if you put a 6 or 8 millimeter balloon, then you're dilating the distal bile duct, which is only 3 millimeters, and I think you may end up disrupting it. So just be careful not to over dilate the distal part of the bile duct.
So the basic message is that one has to look at the diameter proximal as well as distal to the stricture, and whichever is the smaller diameter, one has to be careful in attending to the diameter.
Exactly. Yeah.
So, Rob, what's your approach for about bismuth 3A and 3B strictures? Would you still go for the Ercp or consider PTC guided stents?
So bismuth 3, either A or B, I think are stentable by Ercp, and I do go after those. But you have to. It depends a little bit. I mean, if it's a 3B and the left lobe is really completely atrophied, then you're going to have to spend your time trying to get multiple segments of the right lobe. So it's a combination of atrophy and volume of the tumor. But I think with 3, either A or B, you definitely need bilateral stents.
And in case of Hiler strictures and during the balloon dilatation, do you use any? Do you follow any rule or any measurements to start with?
Yeah, so I'm a little bit conservative, so I tend to, and I'll repeatedly dilate. So I'll have a wire in the right side, a wire in the left side, and I typically will dilate with a 4 millimeter balloon. Occasionally, I will go with a 6 millimeter balloon. But I'll dilate one side, place the stent, and then I'll dilate the other side before I place the stent again. So I repeatedly dilate as opposed to trying to do a big dilation once and then stent everything. So dilating the bile duct in Hiler strictures, I think, is critically important because the forces are against us as we advance, particularly a plastic stent, into a tight Hiler stricture. Much of the force forward through the stricture is dissipated by angles in the distal bile duct. So the forces are dissipated a lot. So you can't have too much resistance within the stricture itself. So I'm a generous dilator for Hiler strictures.
Rob, can I just add on to this question?
Of course.
In your experience, with 4 mm dilatation or 6 mm dilatation, what do you think is the risk of biliary leakage or perforation?
Well, I think it's
low.
Yeah, I mean, I think it's for malignant strictures, particularly if you're going to stent them. I think the risk is really pretty low. And even if you do fracture it, certainly if it's Hiler, there may be liver to sort of protect the leakage, but it's incumbent upon you to make sure that you get a stent in place. If you fracture the tumor, you get a leak, and then you can't stent it, then that may be problematic.
Okay.
Rob, in case of double stenting side by side, do you use any or do you prefer any particular size, especially at the Hiler level?
Yeah, so again, I'm a little bit conservative, and again, it all depends on the distal bile duct. You know, if you need to put two metal stents in, and your distal bile duct is 4 millimeters in diameter, something's going to have to give. So the smaller the distal bile duct, the smaller the stents I'll use. We have some special 6 millimeter stents. We have 8 millimeter, and then we have 10 millimeter. If I have to put them side by side, you know, the small the distal bile.
I understand, Rob, that spyglass is a special technology. It's an expensive tool. But do you use spyglass for selective biliary system cannulation, especially in the proximal strictures?
Interesting. So I have. Where I found it actually most useful is in liver transplant patients, or in post-operative strictures where there's a tiny pinhole and it may be off at an angle, and you can't appreciate that angle under fluoroscopy. In terms of a tumor, at least in my experience, and I'm open to experience from all of you who are also very experienced, when you're up in the middle of a tumor, I don't find spyglass particularly helpful in being able to find, you know, the takeoff to, you know, sort of one side or the other. Now, my experience is limited, but you know, if you're in a tumor stricture, you don't have much articulation on the tip of the scope. You certainly have a lot less articulation than you would with a papillotome or some sort of a bendable a catheter. So at the 6 o'clock position, if the thing takes off at 11 o'clock, you may not be able to articulate the scope to get the wire to go to 11 o'clock. So I haven't found it particularly helpful in cannulating Hiler malignant strictures, no.
Okay, Rob, just to add on to that, please.
Yes.
When you're using the spyglass, are you using wire in place, or do you go in without wire most of the time?
So if I anticipate a really difficult cannulation, if my angles are bad or whatever, then I'll go over a guide wire. But I would say 95% of the time, I like to cannulate freely. Not over wire, just cannulate freely.
Thank you.
I'm a big believer in the suction. I think that a lot of the problems that we get into with a single operator cholangioscopy, there is a rate of cholangitis, and I think that comes from instilling water so that you can see, and then you're filling the water into a closed system. So the suction channel I like to have open, and if there's a guide wire filling it, then I can't get very good suction. So I almost always freely cannulate. You can articulate the end on it just like a papillotome. And so normally you can cannulate really pretty easily. With the spy scope, you don't worry about using the elevator like we did with the baby scope. You know, the spending rubber, but that's not so with the spy scope. You can use the elevator. So I find cannulation fairly easy.
So I think one thing is about there is a do we do better, or percutaneous drainage does better on Bismuth 4?
Yeah, that's I think that my message in my talk was really really critically, because again, to effectively drain a patient, you have to drain 50% of the liver. And if you take into account if there's atrophy or whatever, you've got to plot out getting a stent into enough secondary or tertiary radicals to drain 50% of the liver. And if you can't do that, then putting stents in is just going to introduce infection, and you've not done anything to benefit that patient. So I think, Mohammed, it does happen frequently, not frequently, but we do sometimes embark. We think that we can help a patient with a bismuth 4. We can get in the rest of it, and then we combine our work with the PTC to try to effectively drain all of it. But you know, it leads to lots of problems. Then sometimes if you do PTC and you still don't have adequate drainage, they still can't get appropriate therapy, and now they're the rest of their life they're living with a percutaneous tube. So my message really to the audience, although it maybe sounds cruel, but in some circumstances it's better just to let the patient go to hospice. We can't always help everybody in these bismuth 4 patients.
Rob.
So one other, I think maybe this would be the last one question. One thing is, we all are very enthusiastic. It's a question and a comment as well. So we are very enthusiastic about these metal stents, especially they look really beautiful on X-ray when you have 2 stents across the hilum. So just I have quite a bit reservation about that, putting a metal stents. They have to be uncovered, number 1. Number 2, they are not large diameter. And they really work on patients who have bismuth 3, either A, B, or combination of those. They don't work on bismuth 4. So the bottom line is, if they are gonna work these metal stents, they are bismuth 3. But keep in mind, nowadays, bismuth 3 patients, they live longer, and all the studies follow-up or 12 months follow-up, they don't go beyond that. So these metals stand over a period of 1 year. It is I can assure you, these patients are going to have a tissue ingrowth in that metal stent. And when there is a tissue ingrowth in metal stent, that's a disaster. Repeated infection. So instead of killing them with the cancer, I think we kill them with the repeat. I have a lot of reservation about this, putting a metal stents across the Hiler area, especially in these malignant strictures, which are 3A or 3B, or a combination of those. I don't know, I can take Rob's opinion on that, or somebody else. And also you have to be very careful. Like, once you put those in, they are not. And the picture, the image Rob showed of X-ray, if you want to, they are not across the papilla, and recalculating those could be a
Fire, because you and I talk about this all the time. But
I want to
feel exactly.
I want to support.
Yeah, I do live a long time, and you become married to them. And I do feel strongly about doing no harm. It bothers me a lot when people just indiscriminately put them in, particularly, I don't, it's not ideal to do repeated ERCPs, but when a uncovered metal stent in the hilum, either it's misplaced or it's a precipitous decline for the patient. So I agree.
Can I just ask you, Khalid and Rob and Ghias, if that's the case, Khalid, then do you reckon putting in plastic stents in this particular case would be better? Go back and changing is easy, because once you've placed a metal stent, especially if you've only drained one duct because you got into one duct, and you put a metallic stent, and the patient comes back with blocked opposite system, you have a difficult task going through the stent and putting a wire, or you ask your radiologist to do it, who also find not so they're not so happy once you've blocked the system. So dilating the stent and
PTC, you can do whatever you want. Once you've established that you've got good drainage until you know that you've adequately drained the patient.
That's excellent. Khalid, you said last question. I can't stop asking Rob.
The standard of care now. I think that for me at least, if the anatomy is
Rob has very rightly said that in his setup, he'd like to do one ERCP with fully covered metal stent. But in our setups, I think doing more number of ERCPs with plastic stents and more number of plastic stents makes more sense. So different setups, different priorities, and that makes sense as well.
My point here was my point here was that whether you use multiple stents or whether you use a metal stent, the results of treatment of biliary, post-op biliary strictures is obviously much better than what it used to be since we've started doing both. Yeah. So I think, like, contrary to what that study showed, I think we can be a little bit more confident, as ERCPists or endoscopists, that we are able to help more patients than we did in the past.
Yeah, there's a quick question from one of our colleagues. Is there any contraindication to putting in a SEM stent in suppurative cholangitis?
It has to be a fully covered metal stent, but no, I have no qualms whatsoever about putting in a fully covered metal stent if the anatomy is appropriate and somebody with ever, after you do one of these treatments, as long as there's no obstruction, then they do fine.
Thank you for sparing your time. On behalf of Pakistan Society of Gastroenterology, College of Physician Surgeons, Pakistan, and all the other academic bodies, and my colleagues, Dr. Saad Niaz, Dr. Khalid Hassan, and other colleagues in Pakistan and rest of the world, we are really thankful to you. Sunday, it was your family day, and it's early in the morning in Florida. Colleagues, and best of luck. I wish you a very safe and happy New Year, Christmas, as well as 2021.
Thank you.
Thank you so much. It's a great pleasure. It's great to see you all. Look forward to seeing you in person in 2021. Everybody take care. Thank you.
Okay, bye-bye.